rather than beta blocker.
What I told you, that you can give anything. The main thing is that you have to call the patient next day. If suppose you are giving, suppose you have got about 8-10 patients waiting outside. Your EVAP ready, if I remember correctly, will decrease the heart rate by only 4 to 5 beats per minute or so. If the patient's heart is about 110, 115, and EVAP ready will take some time. Theoretically, yes, but practically not indicated, because everybody wants a quick report, or you can't see that you take evaporated for about 5-7 days and come back again. Anything which reduces the heart rate, whether it is, but because beta blockers is short term, doesn't affect the findings also. So normally we give one dose in the night and one in the morning, because if you give an evaporated, it will take some time also. But but it will reduce by only hardly 5-6 beats per minute or so. Theoretically, yes, but practically may not be very ideal.
Yeah, personally, I feel the ivermectin is more safe than to give beta blocker if mitral stenosis is associated with mitral regurg.
See, the thing is that giving one single dose doesn't matter much.
Okay.
Giving single dose is not that effective. It is not that, unless the patient has got a gross COPD or so. But a single dose will not help. It will not. So you see many. Why do you don't want to give it in MR?
Okay.
So we have given one single
Because
dose
of,
in the night. That's all.
because
So
of
one.
decreased
Uh,
systole of left ventricle. Anyway, you have used the word gain. I'm sorry to ask the very basic question because I've never understood the adjustment of gain. What is adjustment of gain?
I think Dr. Gupta must have told you on the earlier days or so. Said this every equipment has got two things. One is an overall gain. You increase the button, the overall, all extraneous echoes come which you don't like or so. Your whole screen is filled up with different type of echoes. If you decrease the gain, everything looks like it is blank and nothing much is there. So and one is a time gain compensation, in which you can reduce the gain at a selective level. There are about 5-6 knobs. Each knob looks after one particular depth. If you want to reduce the gain at one particular depth, you can use that knob. And overall, it's just a general thing also. And I think
Okay, I
you
got
this
it.
question.
I do it very often. I do it
Eh?
very often, but it was the different nomenclature.
No, but whenever you do an echo, you say you have finished one echo, let us say. When do you come at the second echo? Always look that your all knobs and all things are very correct or so, or how they are working or so. A adjustment of knobs, knobology of one patient may be different from other. So there are two things. A general gain, you see unwanted echoes coming on the screen which you don't like. If you reduce the gain too much, the same structures become very poorly seen. And over there, they become very highly echogenic. So that is the thing. If you go and see the machine tomorrow, then you can see a TGC where you can reduce it at different depth, you can reduce the gain.
Okay, that's fine.
Rupali, can you go ahead?
Yes, sir. Sir, in Wilkins course, how we are grading that subvalvular crowding?
No, that is what I did. What I told you, that the main problem in the Wilkinson score was that uh, did not include the commissions. But I'll come to that slide. So you see, if the Wilkinson score is mobility, say this comprise of the subvalvular apparatus or so. Now, so what I'll do one thing, I did not want to confuse you. that subvalvular apparatus extremely important process in order to guide choice of interventional therapy, determine immediate and long-term outcome following introduction and invasion, and transthoracic echo, parasternal long axis 2C and 3C. That is here or given also. And you see this is all subvalvular apparatus, and the problem was that this was a patient, a young patient of mitral stenosis. You see, a nice opening of the mitral wall, the area is about 1.2 centimeters. And you see good opening. But however, despite this, the gradient was 34 and 33, 23. The area was 1.2 centimeters, and the gradient did not match the area, and it was 34 and 23 extensive. And for a pressure half-time, it was coming to 0.8 centimeters. And then it turned out to be a subvalvular apparatus also. See, the thickening of the subvalvular apparatus at the valve, it is already, but distal you can see this is stenosis. So there was a discrepancy between gradient and the valve area, both by 2D and by other method also. So, but coming to your question also, they do play a part. Extremely important to assess in order to guide the choice of intervention therapy, because sometimes we write determine the immediate and long-term effects following intervention also. That is why we always see then a slight modification of the parasternal long axis and apical views will give you a subvalvular apparatus. Any specific question or other things you wanted to know?
No, sir, just want to.
And Wilkinson, also the problem is that there are many the scoring systems. There is a corneal system which gives importance to cordial and papillary muscles. So there are various scoring systems, but many of you were more aware of this. So what is this rather than having the other ones also.
Dr. Nitin from Belgaum.
Sir, my question is about MVA by pulmonary, that is pressure half time. Sir,
Yeah.
you showed two different envelopes graphs, one with 1.8 square centimeter, one with 1.2. But there was a huge difference in the envelope shape and the way you measure, sir.
No,
Could you just,
what slide? What did you show?
sir, it was written MVA by PHT.
Mitral valve area by pressure half time, sir. That must be atrial fibrillation. He says you measure two different areas. One is 1.2 and second is 1.8.
But the shape of the envelope was totally different, sir. And
right. This is.
You meant to say this one?
No, sir. Previously. It was written MVA by PHT on the top, sir.
Yeah, this is
Oh,
one.
yeah. Okay. Is this one?
Yes, sir.
Ah.
The way, sir, you have measured EF slope here.
We normally call it a deceleration slope, remember.
Okay, sir. But this
So
shape
you
is
see the
totally
pressure
different.
of time was 182. So 220 divided by 182 comes to 1.2 centimeters.
Yes, sir. The other one where you have shown 1.8, sir, that is the next slide where the MVA is 1.8, but the envelope looks totally different, sir. This one.
This one?
Yes, sir. Why is there such a difference in that shape of the apparatus, mitral wall apparatus?
What I wanted to show was that here you cannot measure. What I wanted to tell you was that unless you get a deceleration slope, you cannot measure the pressure half time, correct? So that
Yes, sir.
here you see because there is a very rapid tachycardia also. So you cannot measure a good, every time it will come very low. So you don't see a deceleration slope in this case. So what I mean to say that deceleration slope, so here nothing can be measured. There's no deceleration slope. So what I wanted to say, by reducing the heart rate, you can get a good deceleration slope, and both of them are about 1.8 centimeters. So this is just to show that what happens when you reduce the heart rate and you get a proper deceleration slope. So that was the idea. So that comes to about 1.8 centimeters square.
Sir, what happens if you measure the entire envelope here? Why do we,
When you
where do we
measure
use
the
that, sir?
entire and when you measure the entire envelope, you get peak and mean gradient, but you don't get a sort of pressure of time also. You can get this you can get mean area, mean gradient, peak gradient, and you get a because and VTI also. Because if you see any machine, they've got a different knob for a mitral or deceleration time. So you can measure, but the thing is that when you trace any envelope, then you get a complete thing that we have measured. We told you that you always measure a slope or so that I will show you here. Now you see, here what you say, this is a mitral wall. We have traced the envelope. Now we are getting peak, mean, and VTI, but we are not getting a mitral wall area. So for
Got it,
that,
sir.
there is a different knob, and then you specifically measure here and get this, and because here we have gone from here to here, and you get these parameters also. So a for a pressure of time, we have to measure the deceleration slope.
And sir, should we measure until the foot of the, until that is the notch, or until the end of
What I
the notch?
say, it,
Possibly, sir, they are confused about when you left the envelope at the EA wave. They
Yes,
wanted
sir.
to know if it should come down to baseline or not.
say it doesn't make much difference, but normally what we have been doing, say for example, here you see, say here,
At your level, you should come down to baseline there.
yeah, at your level, you can come to the baseline, no problem.
And sir, you said about the doming, it is actually distal to what structure, sir? Distal to atrium or distal to ventricle, sir?
I always told you that doming is
Sorry, sir, could not hear you.
coming to
Sir, could not hear. Please repeat, sir, please, once more. Distal to.
what I said. I will show you that slide again. That will be better for you. I told you doming of the cusp in the direction of the flow, that is convexity towards the distal chamber. Now you see here, you see the mitral wall. You see the convexity towards the distal chamber, and this is like a doming here. Because I told you the leaflet tips are snow thick, and the annulus is fixed, so the what moves is the body of the ventricle. So that might, when there is a severe stenosis, you may not see a doming, and otherwise you can see what I told you a still image that this is a doming, with the doming toward the. What is your question now?
Sir, to which side we should call as the distal, sir? That's the question. Distal to, you
No,
told.
I mean distal. I am saying distal. I am making it simpler for you. Say this is the LA. This is LV. You see that doming is towards the LA or LV.
LV, sir, here.
LV. Now see this. The doming is towards the aorta also.
Aorta, sir. Aorta.
So what I mean to say in a rough language, that the doming is more toward the distal side, distal chamber.
Where the pressure is less, sir.
Because the valve is moving, the proximal is there. The proximal is here. So it when the valve opens, it opens in a sort of a, because this movement is restricted. Okay, it is only the middle part of the body which moves, which is more mobile. Rest of the valve is fused and restricted in movement. So they get a doming there.
Thank you, sir.
Dr. Anuj Kumar.
Yes, sir. Good evening, sir. In case of stress echo, you said 70% of the target heart rate. So, what is this target heart rate, sir? Suppose the resting heart rate is
What is
78 or
100%?
80.
What is 100% target heart rate?
So, that's what I am asking. What is target
No,
heart
what
rate?
is 100%?
220
That's
minus
what I
8,
am
sir.
saying.
Do you
So
do
suppose,
treadmill? Do you do treadmill?
no, sir.
So,
It
sir,
is 220 minus
220
age.
minus
So
age.
220
Age.
minus
Minus
8
age.
is
Yes.
100%. So there are charts also available which says 70, 80, 90, 85 like this also. So we don't want to exercise them too much. So because if you exercise them too much, then it may not be very good for them. So we exercise till the symptoms occur. The many of the time the symptoms occur if there is a generalized genuine mitral stenosis, the symptoms occur much earlier. So we want, unless if the suppose the patient has no symptoms and then you stop early, it doesn't make much sense also. So till the symptoms occur, or normally we have kept 70% because 70% by 70% the patient usually develop a symptoms and we don't want to give it too much of exercise and they go into a pulmonary edema also. And those, if you don't have a treadmill in your department, I said, let the patient lie on the bed and he can do some exercise, lifting legs, putting down, or he can sit or lie like anything which increases the heart rate.
Okay, sir.
Dr.
So
Venkatesh
one more
Gowda.
question, sir.
Go ahead.
Sorry,
Anuj.
sir. So in case of non-linear Doppler, sir, to measure PST,
Yes.
how to take 2 points, sir, for measuring the slope? Where to take 2 points in case of non-linear wave?
Say normally what happens, we do not measure this. This is a rapid down slope and then there is a concave convexity. What I've shown that if you measure from here to here, what we have been telling you that you measure like this, correct?
Yes,
If you
sir.
measure like this, you'll get a very different value also. So so if you measure here, you are getting an area of about 2.4 centimeters square because this is a steep slope. You don't measure at a steep slope, but you measure at where the slope becomes more horizontal or concave and don't come up to this place, go up to this place only. You follow from the base, go from the line, take this area and go up to this place. So this will be the which came to about 1.4 centimeters or so. So here your question is answered that for your level, you can come up to the base, up to the horizontal line, follow that trace here, and go here. Don't follow it up to this place like this. So that is the deceleration slope.
Okay, sir.
Practice करो तो पता चल जाएगा, no problem.
Okay, sir. Thank you, sir.
Okay, the next person is just a second. Venkatesh Gowda.
Yes, sir. Sir, what is the difference between vegetation and calcification? How we can identify, sir? This is the vegetation and that is the calcification.
Now the difference between vegetation and calcification. Now, so what is a vegetation? Vegetation is usually on the proximal side of the vessel. For example, in a mitral stenosis, it is usually on the atrial side. On a aortic stenosis, usually on the ventricular side. Then they are highly mobile and have got an independent motion as compared to the wall. The calcification is just a calcification of the wall, but these are structures which are moving in and out of the structure you have seen during diastole and systole, and they are where it's got an irregular motion, and then you have an associated clinical. Don't go by echo, clinical picture. Calcification is only the type of the wall. It is only the wall which moves, not the calcium which moves here and there. And again, go for a clinical history. A patient with a valve will have a fever, toxemia, and many other things also. So the valve in an aortic valve, it is attached to the left ventricle side. It shows a very rapid oscillatory movement also. It can be pedunculated and it moves in and out of the structure. But calcium is of course just a morphological feature of a valve. That's all.
Okay, thanks. Thank you, sir.
Dr. Achal, Lucknow.
Sir, just once can you explain in atrial fibrillation, measuring gradients and PHT?
So what I was saying that in atrial fibrillation, there are irregular complexes. Some are narrow, some are broad, some are single line or so. So what I said that in every case of atrial fibrillation, there is bound to be a complex with a wide diastolic slope. So the one with a wide diastolic slope should be studied for a peak and mean gradient and a pressure half time. For example, here you cannot measure, here you cannot measure, here you cannot measure. So go on recording till you get a wide diastolic slope, and then you can measure even the deceleration slope also. And now here the problem that if you measure up to the base, it comes up to this place. So, but that for you is all right. So you can measure peak and mean gradient and area by this method also, rather than having a narrow diastolic. All measurements are always better seen in a wide complex rather than in a complex also. That
And
is why
so, like
sometimes what we do.
like one good is
Pardon me?
enough, or one good complex is enough, or shall we do it in
No,
multiple?
no.
Like,
I told you that you can see this, you can have another complex of nearly the ideal. Suppose 5 complexes are somewhat readable, then you measure all the 5. Otherwise, suppose they are not readable, then again continue and have at nearly the same heart rate again store it. Sometimes you may get a too wide diastolic slope in 1 second, and you measure both and take an average. Ideally, not 1, but should be over 3, 4.
okay, sir. Okay, sir. Thank you.
Because atrial fibrillation is a very complex problem. It will sometimes all hemodynamic findings. That is why in our report, in the end, we always write all hemodynamic findings could have been affected by atrial fibrillation. I find a gradient, I find a mitral valve area. Because of atrial fibrillation, we cannot get a very correct picture also. So always write in the report. It is you take any study abroad, any study of any part of any system, one exclusion criteria is atrial fibrillation.
Dr. Mahesh
Any
Salve.
cardiac research project also.
Yes, sir. How we should differentiate between thickened mitral wall, calcified or sclerotic? So whether which word should be used at what point? Second question is when you are to give the impression for mitral stenosis, whether only orifice size or mean gradient or peak gradient, all three should be taken in consideration for giving the impression for mild mitral
Two things.
stenosis.
First of all, I said he never depend upon one finding. Always take a maximum finding. Correct? For example, I told you that this give you one idea, this gives you another idea, this gives another. But here you see, you have written it is the most method for estimation of severity. If you get a chance, then always measure it a mitral valve area, and you can always measure everything I say. Now, suppose you have made a mistake in measuring a mitral valve area. So don't base your diagnosis only on mitral valve area. You see everything. Always take all the factors and in giving a diagnosis also. Right from commissures, subvalvular apparatus, and mitral area, pressure optimum, everything. So don't leave because you may get the day you start doing a mitral area, one will come at 1.2, other will come at 1.5, third will come at 1.7. So you would have to combine all these and take never, as I told you, give on one single finding. Right from onwards, you have to be there. But if you are asked which is the best method, then you can say nowadays with a 3D echo, this has become much more simpler and more good as compared to 2D.
Dr. Mahmood Iqbal.
Sir, my question is sometimes there is a discrepancy between two values. Like if we consider the area, it looks like severe, but if we look for the mean gradient, it looks like moderate. So what should be the comment?
No. You may say between two persons or yourself. No, the MBO determined by you or 2-3 persons more.
No, sir. Same person, but some values are towards severe and some are like moderate. Like
That is why I said
1.3
that
MBA.
if I remember, I first of all I said in every case, whether it is a normal or not, try to determine a mitral valve area or if it's any LA appendage, so that you can really see what is there or not. Now suppose you find that your area is, say, let us coming at 0.4 or so, and your mean gradient is coming at about 3 or 4. So you see most of the guidelines have not included mean gradient, but usually the mean gradient parallels a bit of a severity of the mitral stenosis. So you have to take everything in picture. Now suppose you are finding, you do it repeatedly. This mitral valve orifice area, and sometimes you'll get slightly more stable findings which are close to each other. But otherwise, take all the findings included and then make a clinical impression. We have not told you the other quantification method because they are usually invalid in cases of a mitral regurgitation or aortic regurgitation. And usually anything which requires a lot of calculations is usually gives a slightly wrong report or so. So always correlate all the findings. Take a zoom method, always take a combination of findings, not one isolated finding.
Dr. Piyush Pandey. Dr. Piyush Pandey.
Good evening, sir. Hello.
Go ahead, Piyush.
Hello.
Yes.
Piyush, can you hear our voice?
Hello.
Go ahead, Piyush. We are able to hear you.
Can you hear me, sir? Because I can't
Yes.
hear you.
Yes, you are audible. Now not audible.
We can go to Dr. Saurabh.
Yes, sir. Very good evening, sir. As you said, sir, in the patients who are having a tachycardia, so it is very difficult to trace the envelope. So it happens quite often. Lots of the patient develops tachycardia or due to anxiety or any other factor in the echo room. So if we do not, as you said, sir, we can give beta blocker metoprolol a night before the study. So if we do not have an option, sir, so can we give ivabradine or metoprolol just an hour or two before the procedure?
Oh, that I told you that the aim is to first try to calm the patient. Now tell them nothing to worry and everything will be all. And I told you the ideal heart rate we have found in near about also. But question is that suppose there is a take lag or so. So again I told I given the answer of ivabradine earlier also. Now if you are in the echo lab, suppose you give a beta blocker, you have to wait for about an hour or two till the heart rate settles down. And it's very difficult to settle down till the patient is fully calmed. So you can give Alprex with beta blocker also. But if you have time to stay for about 2 hours like this also. Otherwise, the simplest method is to call the next day. Suppose the patient is not able to come next day, then you have to give something and just ask the patient to wait for about hour or so. Suppose the patient is outstation, they say, I want an immediate report. Now, what do you do then in those cases? In those cases, because we don't want to give an intravenous beta blocker to reduce the heart rate or so. So the patient can wait till that time you do other cases.
Okay, sir.
And he will get used to the technology then.
Dr. Swapnil?
Yes, sir. Sir, I want to know how to differentiate between atrial myxoma and thrombus.
Yes. Now,
it was my question also, sir.
Yeah, I know. Now, first of all, let us say the thrombus also. Now, in a thrombus usually forms, I'm talking of mitral stenosis. It usually forms when there is a atrial fibrillation, severe stenosis, spontaneous contrast echo, and it can be mobile as we saw within the structure also. So there should be a nidus for the formation of a thrombus. And the nidus will be firstly atrial fibrillation, present of significant stenosis, spontaneous contrast, and another thing. In the atrial myxoma, you see such a large mass, it is always attached to the interatrial septum. You see, it is attached to the interatrial septum, and there goes in and out of the left atrium also. And the patient is in sinus rhythm. There is no spontaneous contrast echo. There is no atrial fibrillation. So this will the presence of these things, the presence of spontaneous contrast echo will all favor the presence of a thrombus rather than the so this way you can slightly differentiate between the two. Again, the clinical situation is very important.
Dr. Piyush Pandey?
Yeah, good evening, sir.
Go
So,
ahead.
which are the different views in which we can examine the left atrial appendage? Am I audible, sir?
Yes, Piyush, you are audible.
So, which are the different views in which we can examine the left atrial appendage?
The view in which you can see a left atrium, one is a parasternal long axis view, correct?
Okay.
Then in a short
Okay,
axis view, below the aorta, you can see the left atrium. Number 3, you can see in a apical 4-chamber view. Number 4, you can see in a subcostal view. So any view.
You told one that corrected short axis view at the aortic wall level, something like that.
That is the short axis view because posterior behind the aorta is the left atrium.
Yeah. Okay.
So these are usually the four views which can give you all the information in a transthoracic echo.
Thank you, sir. Thanks, sir. Can you again
explain that? You can also see a left atrial appendage in the apical views also. Okay. Wherever you see a nice LA, there has to be an appendage. So you can see it in a 2-chamber view also. Try in future.
Okay, sir. Sir, can you explain again that left atrial spontaneous echo contrast thing?
Yes, this what happens in atrial fibrillation?
Yeah.
Why the patient suddenly deteriorate after an atrial fibrillation is that because it reduces the atrial kick is gone, and so the output becomes less. But in these cases, when there is a marked atrial fibrillation or a flutter fibrillation, there is a stasis of the blood flow, and when the ultrasonic beam comes and strikes against these blood components, maybe RBC, WBC, or anything, when the ultrasonic beam they produce a contrast effect, and this contrast effect they produce is known as a spontaneous contrast echo. Why they respond on you? We have got patients of a left ventricular myocardial infarction in which we see a fine contrast echo because of the LV dysfunction. So here we see a coarse movement of the contrast because of the low output state, atrial fibrillation, and the contrast effect, and the ultrasonic beam produces this contrast effect, which of a slow moving components of the blood cells or so. That is the reason. And mostly they are seen when they are a precursor of left atrial thrombus, and hence they are seen more in favor of of uh, mitral stenosis. So that is the reason you can see everywhere. You can see there's a contrast echo. Again, you see there's a contrast echo also.
Right, sir.
So these are a
Thank you,
thrombus.
sir.
Somebody was
Thank you.
asking the difference between a thrombus and this thing. So this is the difference between thrombus. They are mobile structures and associated with a mitral stenosis and the presence of an atrial fibrillation also.
Sir, one of your slide category shows the L appendage, sir.
Yeah.
Parashar short axis view at aorta.
Yeah.
That is the one-sided corrected.
Yeah, it's
Yeah,
look at
this one. Yes.
Piyush, this is what is you go from aorta to papillary muscle, you'll find this appendage opening up just behind the aorta.
Right.
And you see the pulmonary artery disappears at that time. So for the beginners, what we say, for the beginners, what we say that you take a short axis view, let the pulmonary artery come, then gradually move the transducer so that the pulmonary artery disappears, and then you can see the appendage.
Appendage. Thank you, sir. Thank you very much.
And then you can see a thrombus, or even a small thrombus can be seen here.
Anybody else would like to ask questions? Swapnil, you want to ask some question? You're done.
Sir, paradoxical movement of PML.
Paradoxical movement of PML.
Sir, on M mode, how that only, sir, the PML was not seen there.
Dr. Parashar sir is very expert in M mode because he started with M mode.
No, not at all.
Very expert in M mode. He'll show you multiple slides and very clear paradoxical motion.
Yes, sir. Yes.
You said you can't see a posterior leaflet. See, this is a posterior leaflet. This is anterior. It is anterior leaflet. This is the posterior leaflet. Correct? And they are moving in the same direction. You see. So I told you that the one specific sign of an M mode will be a paradoxical motion of the posterior cusp. And the same thing you can see in a 2D also, that the posterior cusp is moving toward the anterior cusp. But M mode has got a different resolution. They can show you better.
You're not able to hear this last.
Yeah, I can see that you cannot hear his voice. Just give it a breathing time. The internet connection is unstable over there. It looks like.
Can you hear now?
Yes, sir. Yes, sir.
So you see, this is the anterior leaflet.
Yes, sir.
This is the posterior leaflet. In a normal individual, they move in the opposite direction. But you see, they are moving in the same direction. And as I told you, atrial fibrillation, see how the complexes vary. One complex, second, third complex, fourth complex, they all vary also.
Okay, sir. Okay.
Sir, those independent two clots in the LA, sir, could they be hydrated cysts, sir? Because they are cystic in nature.
How do you say they are cystic in nature?
Sir, because there is hole inside. They are not full structure, sir. If you can see those TEE structures, transesophageal. Yes, sir. Those ones. Those one before, sir. Two before.
Isme to hai nahi clot.
No, sir. The other one, which you just passed by. Sir. No, sir. Not. No, sir. Those two moving structures in LA, sir. Those clots you
This is not
showed
LA.
through the.
This
No,
is
sir.
not.
Not. Sir, not this. Sir, those two clots in LA, sir, inside. Done by
I was coming to that.
transesophageal. Transesophageal.
Once a patient has got a mitral stenosis, atrial fibrillation, has got a multiple spontaneous contrast echo, then why do you put a possibility of a?
Sir, could they be cystic like this? This is my question. They have got hollow space inside.
No, you say there can be a sort of a small, even a thrombus can show some cystic appearance also. There may be some liquid fraction within the thrombus also. These are usually not the classical.
Yes, sir. I understand. Thank you, sir.
Nitin, what will happen? We'll think of the clot first in presence of mitral stenosis, and then we think of the hydrated cyst.
Yes, sir. Thank you, sir. I understood.
Anybody else? If no more,
is there any sequence? Is there any sequence? Means once on parasternal long axis we see there is rheumatic heart disease, mitral wall is involved. Then what we can go likewise sequence is there?
What do you say?
Sir, is there any sequence? Means once just doing an echo means parasternal long axis view, and we see that it is a rheumatic involved mitral wall is there. Then what sequence wise we should go first like this? Means,
I told you in a suppose now 50% of the patients don't give any history of a rheumatic fever, but the most commonest cause of a mitral stenosis is a just I'll show you your answer question. See, this is the rheumatic. What I showed you, commissural fusion is the predominant lesion, which you don't find in other conditions also. Then again, the same thing, thickened leaflet, they can always be found in various other situations also. But most of these favors more of a presence of a commissural fusion, a multivalvular involvement, and all these bicommissural view, and all these favor a presence of a PML. As I told you, in other situations, you may not get a sort of a fusion also. This was a patient of a, let us say, hypereosinophilic syndrome, but you see there can be a domain here also, but the patient had a thrombus of. But if a patient is of a young individual, say like a 20, a degenerative won't be seen in the age of about 20, 25, 30 or so. They're usually present after the age of 50 or 60. So besides that, if the soul is a younger individual with or without history of a rheumatic heart disease, the presence of a commissural fusion, all these will favor a diagnosis of a rheumatic etiology.
Dr. Mali?
Yes, sir. There is one request. Please explain continuity equation and the pizza.
अरे भैया पिज्जा तो
Dr. Mali, continuity equation and pizza are not your level. What you are doing, Dr. Mali?
Sir, I am ICU registrar.
You are ICU registrar. So you are already doing echoes?
No, sir.
So फिर कहाँ से इसमें आ गए?
No, it's okay.
It is sort of a difficult situation. So I purposely did not bring it also because it requires a lot of calculations also. अभी तो आप forget about, अभी तो बाकी आप practice करो, continuity you can forget a bit later on also. And pizza तो हम लोग हम तो बहुत कम करते हैं, हमने कहा कि any we don't want to waste time. It is mainly a sort of a research project unless you want to write a paper, do a research or so.
At your level, I think Dr. Mali, the best answer is you do a mitral valve area by pressure half time and by planimetry.
Yeah.
All right. Anybody else would like to ask some questions? If there's no more question, let's pay thanks to Dr. Parashar sir, and I'll take my attendance. And those people who have asked question, I've already marked them present. Somebody has posted the leaves. I marked them on leaves. First is Dr. Veerwar Jha from Patna. Veerwar.
Present, sir. Present, sir.
Ankit Seni. Panipat. Dr. Shashank Sunil Tuse. Nasik. Dr. Pallavi Horo. Dr. Pallavi. I can see you, Pallavi. Don't worry about it. Then Dr. Arnab Kumar Mandal, Madina.
Yes, sir. Yes, sir.